This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on health and healthcare disparities. Our special guest today is Dr. Randy Granata, who's Vice President of Population Health at Ascension, and she's a nurse with a doctorate degree in community health and population. Dr. Granata, thank you for participating in this podcast today. As physicians and healthcare workers, we notice a lot of difference in the quality of health that are often linked to a social, economic, or environmental disadvantages. And for this reason today, we wanted to invite Dr. Granata to discuss what are health and healthcare disparities.
Well, thank you for allowing me to be here today. And before we start speaking about disparities, I think it's important for us to bring up really the concept of what health disparities connects to, which is inequities. And for that reason, I just want to speak a little bit about what that means. You touched on the fact that this relates to people or populations that are disadvantaged. But I'd like to even reference, there's a few definitions around disparities. When we think about the Department of Health and Human Services and the way they view disparities, they consider population-specific differences when we look at the presence of disease, of health outcomes, and even access to care. The CDC looks at things even a little more broadly, and then again connects the concepts of health equity and health disparities. Health equity is when all of us have an equal opportunity to attain our full health potential. Right, so no one is really disadvantaged from having access because of a social position or some socially determined circumstance. And the disparities occur when there's actually differences among groups of people. To kind of elaborate, the issue is really complex because we know that there's obstacles that stem generations. They're embedded in our communities, in our infrastructures, in our schools. So it's critical if we're going to achieve health equity and eliminate disparities that we really look at this from a very holistic community health perspective. And there's different types of disparities. We first think of disparities. What naturally comes to mind for me would be race and ethnicity dimensions, but there's more dimensions that would include socioeconomic status, age, language, disability status, whether someone's a citizen or not, and also even sexual orientation. All of these groups or disadvantages can actually drive disparities in health outcomes within our communities.
Yeah, exactly. We have also issues of education, disability, and geographic location. Whether you're in a rural area or whether you're in a city environment, but not quite in a very good neighborhood, can really influence how your health and your healthcare will be processed or perceived, and that will affect also outcome. On that rate, why does it matter? These health disparities.
Well, it matters for a number of reasons. First of all, we have to recognize that there's that moral compass, right? We need to ensure that all of us have the ability to achieve health equity. But it also should enlighten us and tell us how we should do a better job with integrating services and also reaching populations that may be in need of services. You touched on location and geography, and I think it's fascinating that we've reached a point in time now. It's certainly not a good thing, but you can look at zip codes, and we can look at geography, and there's a correlation in some ways to predict health outcomes, chronic disease, and even life expectancy. So why that matters is that really should be providing some insight into our infrastructure, again, the way we even do planning at the community level, beyond our healthcare world.
It's also interesting to see that the minorities that we have now will probably become the majority, in about 25 to 30 years. So I guess, the minorities that we're considering now, taking care of them will influence the future of healthcare.
I'm glad you mentioned that. The most recent U.S. Census report actually called that out and spoke to the fact that the greatest growth, greater than 90% of the U.S. population growth between 2010 and 2018 was in the area of minorities. So it's important that we as health systems and as communities recognize that we need to embrace one another and design care in a way that's going to achieve that equity.
So what is the current status of disparities at the present time?
Sure. Well, I mentioned we have disparities in a number of groups. I think I'll touch on just some of the disparities that seem very apparent today, particularly even in light of COVID. I recently looked at, we all listen to the news, right? And we all hear that we know that the African-American population has been significantly impacted, far more than other groups of people. And we consider COVID. We also know about the connection to heart disease and comorbidities, such as diabetes, and how that impacts outcomes. But what was really enlightening was looking at someone referenced and said, if we looked at all minority groups and in light of COVID, and if they died at the same rate as Caucasians, we would have actually had 13,000 less African-American deaths, 1,300 less Latino Americans, and 300 Asian Americans would still be alive today. That was pretty powerful and really called out the fact that COVID has just magnified disparities that exist. And of course, there's different disease, there's different prevalence among different groups. When you consider the American Indian population, we know that there's efforts happening in tribal health to correct for disparities. So the current state, we know that 30% of American Indians live in poverty. Of course, that's interconnected, right, with health outcomes. When we consider also our Hispanic population, we have there's evidence of poor oral hygiene, dental health. We have higher rates of diabetes as well. And when we think about geographical disparities, back to that area, we live in the stroke belt, right? So we know, again, there's overlap when you consider different racial populations and demographic data, and we know that it's impacting disproportionately African Americans in the stroke belt.
It's kind of interesting. We were looking at higher rates of chronic disease and premature death in our minorities. Interestingly, I was reading at some point that the Hispanic immigrants have better health outcomes than white. And this immigrant paradox appeared to diminish with time spent in the United States. Really kind of interesting to see how the socioeconomic as well as environmental factors affect your health.
Sure.
Obviously, there's all the field of HIV, where the magnitude of African American and wide disparity in AIDS diagnosis and mortality has just grown substantially over time and keeps growing. Something that we're not very familiar as cardiologists, but also infant mortality, very much related to disparity. more in what concerns us and our patient is the problem of obesity, having, for example, the Hispanic children and adolescents, age 2 to 19, had the highest prevalence of obesity in the United States at almost 22%, with Asians having the lowest at 8.6%. Mexican Americans suffer disproportionately from diabetes and very much, related to this obesity problem. Obviously, we're in the field of heart disease, having African Americans were 30% more likely than whites to die prematurely from heart disease. This was in 2010, and I don't think it's improved, very much since that time. African American men were twice as likely as white to die prematurely from stroke, as you mentioned, earlier. And if we look at all the age-standardized cardiovascular death over the last 15 years, obviously among all the groups, there's a trend for a decrease in mortality. However, African American or blacks remain the highest mortality group, followed by white, and then followed by Hispanic, American Indian, and then Asian or Pacific Islanders. So those patient population really, and the minorities really affect the outcome in our health research. And what can we do? What are key initiatives that are being taken to address the disparities?
Sure. What comes to mind, I'll first begin, since you just mentioned all of those really powerful statistics around higher incidence of disease among certain at-risk groups. What comes to mind is really screenings, right? And the importance for us to make sure that the ability to screen for disease states is accessible and affordable to those individuals and communities who may be at risk. When I think about even the African American population, cancer is also, it comes to mind, even for individuals who are insured. We see that cancer is diagnosed later when it's more progressive, and the outcomes are poorer and the mortality is higher. But what I would really like to call out is really the connection to social determinants of health. And I know that has been kind of a buzz phrase in the last few years. And to go a little bit deeper here, if we're going to impact disparities in health equity, we need to understand what those levers are, right, within our communities, and recognize that there's some things that we can influence and that communities can also become empowered to influence. One of the things that comes to mind is access to healthy foods. When you consider just about every chronic condition, we know that it's linked to healthy food and healthy water, right? We have food deserts within our country. We have hundreds of communities with food deserts, including in our state of Alabama. And what that means is it's where at least a third of the community does not have a healthy options for food within a reasonable distance. So it doesn't mean that there's a lack of food. It's usually fast food. And because of this, we see increased incidence of disease. When healthy food is available, it's not affordable for certain populations. So again, it's about how we can help empower communities to bring those resources and start to eliminate food deserts across our state and our country. Other things we can do is partner with community agencies and also recognize that we need an interdisciplinary care team. And I think most of us are doing this today. That means that we may have social workers, care managers, mental health workers working within our, whether it be practices and even at the community level, to help advocate for patients and get them the resources that they need. Oftentimes, even when patients have access to care, they cannot afford their co-pays or even afford the medications that are prescribed. So it's so important that we as a community recognize that that the social determinants really drive those health outcomes for the people that we're serving.
One of the goals of Ascension is to eliminate healthcare disparities by 2022. Do you think this is doable?
Well, I am certainly, that's why I come to work every day, being part of an organization that has a goal that big. And I'd like to believe that we can. It's going to take some intentional work. And I believe Ascension's on the right track. And we also challenge ourselves to really look at our data to be sure that we are using those metrics and those ways of really challenging ourselves to ask, are we reaching the population to truly eliminate health disparities and achieve health equity? Our mission statement is all about caring for the poor and vulnerable. So the more we can challenge each other to live out our culture every day and our mission, the closer we're going to get to that goal. But it's going to take some intentional work. I believe it is happening. But again, there's complexities within our communities, such as unemployment, right? There's COVID, right? We've had a pandemic that has just exacerbated some of those economic challenges that existed pre-COVID. But I would like to believe we're going to get there, but it's going to take all of us working together.
I really like, even though it can be a little tedious process, but with the freezer pad, patient coming to your office, entering all this data. But this is actually very, very important to really, I think we have some gaps in the data that, things that we need to measure, to evaluate, to analyze, so we can really be more appropriate in the care of certain patient population and, and probably answer the need better to some of these patients. Certainly this situation with COVID did not help with having a group of patients at risk of losing their insurance, losing their job. The socioeconomic status has just kind of worsened, and certainly it creates even more difficulties and more need, I think, for pulling together. But I think if we just kind of strive to a quality care and measuring a quality measurement and reassessing, what other current challenges do you see in addressing disparities?
Sure, great question. I think some of our challenges relates to engagement with our community, especially COVID. When we're considered the social distancing, we have to get more creative with doing outreach to our community and recognize that the chronic disease problems did not go away during COVID, right? If anything, we have delayed care. So there's a need for doing even more intentional outreach. I know that I can just speak from within our health system. We have an outreach team that includes a social worker, a nurse, and lay navigators who some are bilingual, and we are doing intentional outreach to make sure that people have the medications that they need, that they're seeing their primary care doctor, and when they can't, we're doing our best to have a virtual visit, including leveraging the use of nurse practitioners. And again, finding ways that people are really just comfortable relating to their healthcare team, not waiting for that crisis when they are showing up in the emergency department, and it's much more difficult to treat the patient. So I think, again, COVID is just, there's some great things that have come out of COVID, again, as I mentioned, and I can't imagine 5 years ago that we would have had our outreach team communicating in the way we are today with an underserved population using technology and basic tools such as smartphones.
President and CEO of Ascension, Joe Impichike, really has a great motto, saying that healthcare that works, healthcare that is safe, and wanting to leave no one behind. Mm-hmm. Certainly, as a healthcare worker, whether you're a nurse or a physician, we want not only what's best for our patient, but to do everything we can, in our powers, to provide care for these patients. And this is where I think it really becomes very important to work as a team.
It sure does. And when we are redesigning care, consistently putting that lens on and looking at it from the eyes of our patients at all levels and different communities, and understanding barriers, and when possible, including those participants at the community level. And when we start to redesign care, that's been a part of what we have been intentional about, but I think we can always do better in that area.
Whether you work at a hospital, within a university, or within a large healthcare community, or whether you're a rural hospital, I think this has become a system-wide priority, and obviously demands a lot of infrastructure development, which I believe it's one of the goals, certainly at Ascension, as well as cultural transformation to really provide a kind of compassionate and personalized care that needs to be done for our patients. Again, thank you very much for being part of this podcast. We appreciate it. I think we have learned a lot today. Thank you.
Thank you. Appreciate it.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.